Welcome back to the deep dive. Today, we're really digging into the clinical roadmap for antenatal care. Our sources, well, they lay out pretty much everything you'd need to know.
Yeah, from the very first inkling someone might be pregnant, all the way through, complex genetic tests, and even how to handle some serious complications.
Exactly. And for you, the learner, listening in, think of this as organizing a huge amount of information.
Right. Our mission today isn't just listing facts. It's about building a structure, a flow,
Mm-hmm.
moving from those initial signs right through to managing risk proactively.
I like that, a structured flow. Okay, so let's start right at the beginning. How do we even confirm a pregnancy? The sources talk about 3 tiers of signs, don't they?
They do. It's a really logical system, actually. It helps separate subjective feelings from objective proof. The first tier, that's the presumptive signs.
Ah, the least reliable ones.
Well, yeah, because they're totally subjective. It's what the patient experiences or feels, things only they know.
So this is the stuff most people know about. Missing a period, feeling sick, being really tired, having to pee all the time, breast changes.
All those classic early signs.
And the sources mention quickening too, that little fluttery feeling.
Right, quickening. That slight movement the patient might feel, usually somewhere between, 16 to 20 weeks.
Yeah. It feels significant, but like you said, it's subjective, not actual proof.
Exactly.
Yeah.
So then we move up a level to the probable signs.
Okay, so these are more objective, things a doctor or nurse can spot.
Correct. An examiner can detect these. But, and this is key, they still aren't 100% definitive proof.
Why not?
Because other things, hormone issues, sometimes even certain tumors can actually mimic these signs.
Ah, okay, so this is where those specific clinical terms come in. I saw Goodell's, Chadwick's, Hagar's sign.
You got it. We can group those three together. They're all about softening or color changes.
Mhm.
Goodell's sign is the softening of the cervix itself.
Okay.
Chadwick's sign, that's the one where the cervix and vaginal lining look kind of bluish or purplish.
Right, due to increased blood flow.
Precisely. Increased vascular congestion
Yeah.
plus hormones. And then Hagar's sign is that noticeable softening right at the bottom of the uterus, the lower segment.
Makes sense. So those signs, plus maybe a positive pregnancy test from urine or blood?
Mm-hmm. And Braxton Hicks contractions, those practice contractions,
Mhm.
plus something called ballonnement, where the examiner taps the cervix and feels a rebound.
Okay, so all of those point strongly towards pregnancy, but aren't the final word?
Exactly. They push the evidence way up, but for absolute certainty, you need the third tier, the positive signs.
The definitive proof?
Yes. According to our sources, there are only 3 things that absolutely, positively confirm pregnancy. No other condition causes them.
And what are those 3?
Okay, first, hearing the fetal heart sounds.
Mm.
That separate, usually faster heartbeat.
Got it.
Second, actually seeing the embryo or fetus on an ultrasound, that's pretty undeniable.
Very clear. Yeah.
And third, feeling fetal movement, but importantly, it has to be felt by the examiner during an assessment, not just reported by the patient.
Okay, so one of those 3 and the diagnosis is confirmed.
That's it. Confirmed.
All right, so pregnancy confirmed. Now let's shift gears, like you said, towards proactive care and risk management. This means testing, right? Starting with standard labs.
Yep. And there's quite a bit of baseline lab work needed pretty early on. We can kind of group it. First, the basic blood checks.
Like a CBC.
Right. Complete blood count looking for anemia or infection.
Yeah.
And then blood type and RH factor. That RH factor is super important. We'll definitely circle back to that one.
Okay. What else in that initial sweep?
Then you've got the immunity and infection checks.
Mhm.
Really important. You need the rubella titer to check immunity status.
Mm-hmm.
And then screenings for hepatitis B, syphilis, that's the RPR or VDRL test, HIV, and also gonorrhea and chlamydia.
Wow, that's a comprehensive panel right at the start, all about protecting parent and baby.
Absolutely vital.
Yeah.
And then there are other checks that happen at specific times during the pregnancy.
Like the glucose test.
Exactly. The OGTT, oral glucose tolerance test, that screens for gestational diabetes, usually done around 24 to 28 weeks.
Okay.
And then later, around 37 or 38 weeks, there's the GBS test for group B streptococcus.
And isn't there something done at every visit?
Oh yeah, the simple urinalysis.
Hmm.
Just checking urine for protein and glucose at every single appointment. It's routine.
Gotcha. Okay, moving from those routine checks, let's talk about genetic screening. This can feel complex. The sources had some helpful ways to remember the patterns, starting with MSAFP.
Right, the maternal serum alpha-fetoprotein. Its main job is screening for a few key things. Neural tube defects, or NTDs.
Like spina bifida.
Exactly. Also Down syndrome, or even if there might be multiple babies, like twins.
And there was a mnemonic.
Yes, this is super helpful. Remember Down, meaning low AFP, often correlates with Downs, and up, meaning high AFP, correlates with NTD.
Down is Downs, up is NTD. Okay, that simplifies it.
It gives you a quick pattern recognition for two major possibilities.
Then there's the quad screen, which adds more markers.
Yeah, it takes the MSAFP and adds three more: HCG, unconjugated estriol, UE3, and inhibin A. Putting all four together makes the patterns even more specific.
So what would a pattern for Down syndrome look like on the quad screen?
Okay, so for Down syndrome, you typically see high HCG and high inhibin A, but low UE3. The AFP is often low too, fitting our mnemonic.
High HCG, high inhibin A, low UE3.
And conversely, if you see low levels across all four markers, AFP, HCG, UE3, and inhibin A, that pattern is often associated with trisomy 18. It's the combination of the pattern that's telling.
And what about NIPT, non-invasive prenatal testing?
NIPT, that's a blood test too, but it works differently. It actually analyzes tiny fragments of fetal DNA that are circulating in the mother's blood. It's very good for screening for chromosomal abnormalities.
Sounds powerful, but there's a really important point here about all these blood tests.
Yes, absolutely critical. MSAFP, quad screen, NIPT, these are all screenings.
Meaning they don't diagnose, they just indicate risk.
Precisely. Screening tells you the risk might be higher. It gives you information to consider, but it doesn't give you a definitive answer. For that, you often need diagnostic tests.
Which are usually more invasive.
Correct. The two main ones are amniocentesis and chorionic villus sampling, or CVS.
Okay, tell us about amnio first.
Amniocentesis involves taking a small sample of amniotic fluid. It can diagnose genetic disorders directly. Later in pregnancy, it can also check fetal lung maturity by looking at the LS ratio.
Is it risky?
There's a small risk, yeah.
Okay.
Usually quoted as less than a 1% chance of miscarriage. And a key nursing point: the patient needs to empty their bladder right before the procedure.
Good tip. And CVS?
Chorionic villus sampling, or CVS, takes a tiny piece of placental tissue, the chorionic villi. It also diagnoses genetic conditions, and the advantage is it can often be done a bit earlier in pregnancy than amnio.
Similar risk.
Yeah, roughly comparable, around 1%. Because these tests involve entering the uterus, they carry that inherent risk, which is why they're generally reserved for situations where screening results are abnormal or there are other high-risk factors. They provide answers, but there's a potential cost.
Okay, that clarifies the screening versus diagnostic difference. So we've covered routine checks and planned testing, but sometimes things go wrong unexpectedly. Bleeding during pregnancy must be scary.
It is. And the timing of the bleeding often gives us the first clue about the possible cause.
How so?
Well, if the bleeding happens in the first trimester or maybe early second, the big concerns are usually miscarriage.
Which is often due to chromosomal issues, right?
Most often, yes. Or it could be an ectopic pregnancy or something called gestational trophoblastic disease, GTD.
Okay, and if the bleeding happens later, say in the second half of pregnancy?
Then the worries shift completely. We start thinking about problems with the placenta, like placenta previa or abruptio placentae.
Let's focus on ectopic pregnancy for a moment. That's when the embryo implants outside the uterus.
Usually in the fallopian tube, yeah. It's dangerous because the tube isn't designed to stretch and can rupture.
What makes someone higher risk for that?
Often it's related to previous damage to the tubes, maybe from PID, pelvic inflammatory disease, or prior tubal surgery. Even having an IUD in place can slightly increase the risk of an ectopic if pregnancy does occur.
And what are the warning signs? What should you look out for?
Key signs include sharp, often stabbing pain, typically on one side of the lower abdomen.
Unilateral pain, okay.
Also a missed period,
Yeah.
amenorrhea, and some vaginal bleeding, which might be light or heavy. But the real red flag, the one that often signals rupture, is shoulder pain.
Shoulder pain, that seems unrelated. Why the shoulder?
It's referred pain. If the tube ruptures, blood can leak into the peritoneal cavity and irritate the phrenic nerve. That nerve irritation is felt up in the shoulder area. It's a critical sign.
Wow, okay. Anything else?
Clinically, we'd also look at HCG levels. In an ectopic, the HCG levels tend to rise much more slowly, or plateau, compared to a healthy intrauterine in pregnancy.
And how is an early unruptured ectopic treated? I saw methotrexate mentioned.
Right. If it's caught early and hasn't ruptured, methotrexate can sometimes be used.
Isn't that a chemotherapy drug?
It is. But here, it's used in a specific way to target and stop the rapidly dividing fetal cells. This allows the body to gradually absorb the pregnancy tissue without surgery.
Are there special instructions for someone taking methotrexate for this?
Oh, absolutely. Patient teaching is crucial. They must avoid folic acid supplements, even fortified foods, because folic acid interferes with how methotrexate works.
Okay, no folic acid. What else?
No alcohol, no NSAIDs like ibuprofen, and no strenuous activity. And maybe most importantly for safety, they need reliable contraception for at least 3 months after treatment. You have to be sure the ectopic is fully resolved before risking another pregnancy.
Makes sense. And if it ruptures?
Then it's a surgical emergency, usually requiring removal of the tube, salpingectomy,
Okay.
or repairing it,
Hmm.
salpingostomy.
Okay. Now, another cause of first trimester bleeding you mentioned was GTD, hydatidiform mole.
Yes, gestational trophoblastic disease, often called a molar pregnancy. It's a weird one, basically. It's an abnormal growth of the cells that normally form the placenta.
What does that look like clinically?
It's often quite distinct.
Hmm.
You might see vaginal bleeding, but it's frequently described as dark brown, like prune juice.
Okay.
And importantly, the uterus is often larger than you'd expect for the supposed gestational age. Plus, the HCG levels are usually sky high, much higher than in a normal pregnancy or even twins.
And there's a long-term concern with GTD.
Yes, there's a risk that some abnormal cells could persist and potentially develop into a type of cancer called choriocarcinoma. So careful follow-up with regular HCG monitoring is essential after treatment.
Right. And speaking of those super high HCG levels, they're also linked to hyperemesis gravidarum, aren't they? HG.
They are strongly associated, yes. HG isn't just regular morning sickness. It's severe, persistent nausea and vomiting that can lead to dehydration, weight loss, and electrolyte imbalances. It's debilitating.
So the nursing focus must be on.
Fluids and electrolytes. First and foremost, you have to assess their hydration status constantly. Get IV fluids running, give antiemetic medications. Simple things help too, like keeping food odors away. In really severe cases, if they can't keep anything down, they might even need TPN, total parenteral nutrition, feeding through an IV to prevent malnutrition.
Wow, that's intense. Okay, let's move to our final deep dive area, RH incompatibility. This feels like a cornerstone of preventative antenatal care.
It absolutely is. It's one of those areas where understanding the mechanism allows for really effective prevention.
So break down the basics. What is the RH factor?
It's simply a protein found on the surface of red blood cells. If you have the protein, you're Rh positive. If you don't have it, you're Rh negative.
Okay, so where's the problem?
The problem arises, potentially, when an Rh negative mother is carrying an Rh positive baby.
Her body doesn't have the protein, but the baby cells do.
Exactly. If some of the baby's Rh positive blood cells cross the placenta into the mother's circulation, which can happen during pregnancy, but especially during delivery or certain procedures, her immune system might see that Rh protein is foreign.
Like an invader.
Right. And her immune system might react by creating antibodies against the Rh protein. This process is called sensitization.
And this usually doesn't hurt the first Rh positive baby.
Generally not, because significant exposure often happens late, or the antibody response isn't strong enough the first time. But her immune system now remembers it's sensitized.
So the risk is really for future pregnancies.
Yes, specifically for future Rh positive babies. If she gets pregnant again with an Rh positive fetus, those anti-Rh antibodies she developed can cross the placenta and attack the baby's red blood cells.
Causing anemia and other problems for the baby.
Exactly. Hemolytic disease of the newborn. But this is largely preventable now. First step is knowing the parent's Rh status. If the mother is Rh negative and the father is also Rh negative, then there's no risk the baby will be Rh negative too.
But if the father is Rh positive,
Then the baby could be Rh positive, and there's potential risk, which is why ROGAM is so important.
ROGAM. What is it exactly?
It's an injection of Rh immunoglobulin. Think of it like it tricks the mother's immune system. It essentially finds and neutralizes any Rh positive fetal cells in her circulation before her immune system gets a chance to notice them and make its own long-lasting antibodies.
So it prevents sensitization from happening in the first place.
Precisely. Prevention is key.
And when is ROGAM given?
Standard practice is a preventative dose around 28 weeks of gestation for all Rh negative mothers.
Okay, 28 weeks.
Then after delivery, if the baby is confirmed to be Rh positive, the mother gets another dose within 72 hours.
Within 72 hours postpartum. Got it.
And crucially, ROGAM should also be given to an Rh negative woman anytime there's a chance of fetal blood mixing with hers after a miscarriage, an abortion, amniocentesis, CVS, any trauma to the abdomen.
Basically, any event that might cause exposure.
Yes,
Ugh.
better safe than sorry.
Now, how do we know if the mother is already sensitized? If your immune system has already made those antibodies from a previous exposure, that's where the Coombs tests come in, right?
Exactly. And it's important to distinguish between the two Coombs tests. The indirect Coombs test is done on the mother's blood.
Okay, indirect mom, what's it looking for?
It's looking to see if she already has those anti-Rh antibodies circulating in her blood. Has sensitization already happened? This is usually checked early in pregnancy and again around 28 weeks before the routine ROGAM shot.
And if the indirect Coombs is positive,
If it's positive, it means she's already sensitized. Giving her ROGAM at that point won't help because the antibodies are already there. Management then focuses on monitoring the baby closely for signs of hemolytic disease.
okay. So indirect Coombs checks mom for existing antibodies. What about the direct Coombs?
The direct Coombs test is done on the baby's blood after birth, usually from the cord blood.
Direct bod baby. And it checks.
It checks to see if the baby's red blood cells are already coated with the mother's antibodies that have crossed the placenta. A positive direct Coombs test confirms that the baby has been affected by the maternal antibodies and helps diagnose hemolytic disease of the newborn.
Indirect for mom's potential, direct for baby's reality. Makes sense.
That's a good way to put it.
Wow. We really have covered a huge amount of ground today for you, the listener. We went from those first subjective, presumptive signs.
All the way through the details of genetic screening patterns, the critical management of bleeding, ectopic pregnancy.
And just now, drilling down into Rh incompatibility and prevention, it really is a comprehensive roadmap of antenatal care.
Understanding these steps, the tests, the potential complications, and why things are done, it's just fundamental for safe care and achieving the best outcomes.
It truly is. Now, as you continue to think about all this, consider the level of precision needed for monitoring fetal well-being during the pregnancy.
Yeah. We talked about diagnosis and managing problems, but ongoing surveillance is key. Think about the non-stress test, the NST. It's often part of a
Yep.
biophysical profile.
Right. What's the provocative thought there?
Just the sheer specificity required for a good result. For instance, our sources note that for a pregnancy at 32 weeks or later, a reactive NST, meaning a healthy test, requires very specific criteria.
What are they?
You need to see at least 2 fetal heart rate accelerations, where the heart rate goes up by at least 15 beats per minute above the baseline.
Okay.
And each of those accelerations has to last for at least 15 seconds. And all that needs to happen within a 20-minute window.
15 beats up for 15 seconds, twice in 20 minutes after 32 weeks.
Exactly. That 15 by 15 rule, or 10 by 10 earlier in gestation, it just highlights the incredible precision involved in assessing fetal health minute by minute. It's not vague. It's highly specific monitoring.
That's a fantastic point about the detailed standards of care. A great place to wrap up. Thank you for diving deep into these clinical notes with us today.